Hey everyone and welcome. In the super fast-paced world of anesthesia, choosing the right intravenous agent is a critical decision we make every single day. So today, we're going to sharpen our skills with a deep dive into our IV toolkit. We're going to focus on how to match the right drug to the right patient every single time. Let's get into it.
So let's just jump right in with a scenario that gets right to the heart of what we do. You've got a patient with reactive airways and they're decompensating fast. The clock is ticking. Your choice of induction agent could either calm everything down or make things catastrophically worse. Keep this question in the back of your mind. We are definitely going to circle back to it with a solid answer.
It's really best to think of our intravenous agents like a specialized set of tools. Each one is incredibly powerful for sure, but none of them is a one-size-fits-all solution. The real art and science of what we do lies in understanding the unique properties of each drug so we can tailor the anesthetic to that specific patient's physiology and whatever the surgery demands.
Okay, so if we're going to master this toolkit, we've got to understand how the tools actually work. For most of our go-to induction agents, we're talking barbiturates, benzodiazepines, propofol, and etomidate, the main target is the GABA-A receptor in the brain. Think of this as the master off switch for consciousness.
So what is GABA anyway? Well, to put it simply, it's the brain's main brake pedal. When GABA binds to its receptor, it opens up a little channel, letting negative ions flood into the neuron. This makes that neuron way less likely to fire. Our drugs, they don't replace GABA. They just make it work a whole lot better.
Now, this is where it gets really interesting. This slide shows a subtle but absolutely crucial difference in how these drugs work. Both barbiturates and benzos boost GABA's effect, but they do it in different ways. Barbiturates increase the duration. They hold that channel's door open longer. Benzos, on the other hand, increase the frequency. They make the door open more often. This little distinction has some pretty big clinical implications.
All right, so now that we've got the basic science down, let's get to the really important part, the clinical application. We're going to run through a few common high-stakes scenarios to see how our drug choice has to change based on our patient's physiology. First up, let's tackle neuroanesthesia. Imagine you've got a patient with a traumatic brain injury, maybe a tumor or a bleed. Your number one goal is to protect that brain, and that means controlling intracranial pressure, or ICP, is everything. So, which tool do you reach for?
Okay, so let's look at our options here. Barbiturates are these really potent cerebral vasoconstrictors. They cause a huge drop in cerebral blood flow and intracranial pressure, which is exactly what we want, and that often improves cerebral perfusion. Propofol does something similar, just not quite as dramatically. Now look at ketamine. For years it was a big no-no because of ICP concerns, but modern evidence shows that as long as you're controlling ventilation, the ICP doesn't really change, making it a perfectly good option in some situations.
All right, let's switch gears to another super high-stakes situation, the hemodynamically unstable patient. This could be a trauma patient, someone with raging sepsis, or a patient with a very weak heart. Here, your choice of induction agent could either support them or cause a complete cardiovascular collapse. The stakes just couldn't be higher.
And our choice here? It's absolutely critical. Propofol, it causes major vasodilation and myocardial depression. That's just dangerous in a patient who's already in shock. On the other hand, you've got Etomidate, which is famous for its rock-solid hemodynamic stability. And then there's Ketamine, which actually kicks the sympathetic nervous system into gear, jacking up blood pressure, heart rate, and cardiac output. This makes it a fantastic choice for, say, a hypotensive trauma patient.
Okay, remember that question we started with? Let's circle back to it now. The patient with asthma. This is a challenge we see all the time, and our choice of agent is just critical to avoid causing bronchospasm, especially during a vulnerable time like intubation.
And here's the answer. The really crucial thing to get is that it all depends on the patient's status right now. For a patient with stable, well-controlled asthma, propofol is a great choice. It almost never causes histamine release, and it's not irritating to the airways. But for our patient from the start, the one with unstable asthma who's actively wheezing, ketamine is the clear winner, no question. Why? Because ketamine is a powerful bronchodilator. It can actively help open up those airways, making it a therapeutic choice, not just an anesthetic one.
So we've talked a lot about putting the patient to sleep, but that's only half the battle, right? Now we got to talk about pain. For decades, the absolute mainstay of intraoperative analgesia has been the opioid class of drugs.
Not all opioids are created equal, not by a long shot.
And this slide really shows you why pharmacokinetics is everything. On one end of the spectrum, you've got remifentanil. It gets chewed up by esterases right there in the blood, which gives it this incredibly short, predictable half-life of about 3 minutes, no matter how long the infusion's been running. Perfect for precise control. On the complete other end, you have an older drug like mepridine. It's metabolized by the liver into a toxic metabolite, norepinephrine, that can build up in patients with bad kidneys and actually cause seizures. See? 2 opioids, 2 totally different stories.
But of course, these days, it's all about a multimodal approach to pain. We don't just lean on opioids anymore. Adjuncts, like COX inhibitors, play a huge role in giving us a more robust, opioid-sparing anesthetic.
So here's a quick and dirty rundown of what you really need to know. The classic NSAIDs, they inhibit COX-1, which messes with platelet function, so yeah, they increase bleeding risk. The selective COX-2 inhibitors spare the platelets, which is great for surgery, but we always have to think about their cardiovascular risk profile. Aspirin is in a league of its own, with its irreversible platelet inhibition. And then you've got acetaminophen, which works centrally and has 0 effect on platelets, making it a super safe and effective part of our plan.
Okay, to wrap this up, let's do a quick rapid-fire round of clinical pearls. These are the critical, must-know facts and warnings that can really make or break a case and, most importantly, keep our patients safe.
See this number? pH greater than 10. You need to burn this into your brain. That's the pH of a standard thiopental solution. It is extremely alkaline, and that is why an accidental intra-arterial injection is a true code blue medical emergency. It can cause intense vasospasm, thrombosis, and just catastrophic tissue injury.
So if this nightmare scenario ever happens, you have to act, and you have to act fast. First, leave the catheter in place. The whole protocol involves trying to reverse that vasospasm with vasodilators, preventing clots with heparin, and then performing a sympathetic blockade, like a stellate ganglion block, to force more blood flow to that limb.
All right, here's a more lighthearted one, but it's pretty fascinating. Don't be surprised if your patient mentions tasting something weird, like garlic or pizza, right as they're drifting off to sleep with thiopental. It's a real, well-documented thing, and it's a great piece of trivia that also happens to be a clinical sign that your IV is in the right place.
Okay, these next few are the absolute, non-negotiable safety rules. The interaction between mepridine and MAOIs is completely contraindicated. It can be fatal, period. Remember, Etomidate is great for induction, but it suppresses the adrenal glands, so it should never be used for long-term sedation. And finally, Propofol. It's a lipid emulsion, which is like a perfect dinner plate for bacteria. Strict sterile technique is mandatory, and you have to throw out an open vial after 6 hours. No exceptions.
And this is a huge red flag that every single one of us needs to have on our radar. Propofol infusion syndrome, or PRIS. It's a rare but devastating complication that we see with high-dose, long-term infusions, especially in younger patients. You have to be vigilant for any unexplained metabolic acidosis or cardiovascular instability in any patient who's been on a propofol drip for a while.
And that, it brings us to one last big thought to leave you with. We now know that high doses of opioids, especially super potent ones like remifentanil, can paradoxically make patients more sensitive to pain after surgery. This phenomenon, opioid-induced hyperalgia, is a major challenge for us. It really forces us to ask, are we moving towards an era of opioid-free or at least opioid-sparing anesthesia? It's a critical question, and the answer is going to shape the future of our practice. Thanks so much for joining me for this explainer.